So hello and welcome. My name is Dr. Joshua Sabari. I'm a thoracic medical oncologist at NYU Langone Health Perlmutter Cancer Center in New York. And I'm excited to be joined by my colleague, Dr. Daniel Araujo. So Dr. Araujo, please introduce yourself.
Thank you so much, Dr. Sabari. My name is Daniel Araujo. I'm a GU medical oncologist at University of Florida, Gainesville. It's a pleasure to be here.
So Daniel, welcome. And I'm also the editor-in-chief of Cure. And we're excited for you to give us some of the ASCO updates from the GU or genitourinary space. So walk us through, what were some of the exciting takeaways from this ASCO 2025?
Thanks a lot. So ASCO, as you know, is always a great meeting to attend, and numerous abstracts are presented and data is consolidated. So this year, in particularly in GU, we saw some interesting stuff. Perhaps the most practice-changing abstract would be the AMPLITUDE trial. So this is a randomized controlled trial investigating the role of niraparib, which is a PARP inhibitor, in the context of hormone-sensitive prostate cancer metastatic patients. So PARP inhibitors they already have an established role in patients with castration-resistant prostate cancer, and now the PARP inhibitors are for the first time being tested in the hormone-sensitive setting. So essentially, patients with HRR, which is homologous repair defect genes, they were randomized to receive niraparib plus abiraterone versus abiraterone single agent. And this population is about 30% of all patients with prostate cancer. So a minority, but this group is known for having more aggressive disease with worse outcomes. So essentially, the addition of niraparib to abiraterone was able to extend progression-free survival, especially for patients with BRCA mutations. So this is yet to be, it was probably will be assessed by FDA and regulators and other trials with different molecules other than niraparib are being tested in the same space to see if this is a class effect, and probably is akin to what we see in the castration-resistant space.
So Daniel, this is an exciting space. We see approvals in breast cancer. We see approvals in pancreatic cancer. What are some of the side effects that patients should know about some of the PARP inhibitors?
Yeah, no, great question. So PARP inhibitors, they have some class effects, and these are essentially toxicity to the bone marrow in terms of anemia, neutropenia, plaquetopenia. So before like dosing each cycle, we usually repeat blood work to make sure that patients have blood work within reference range, and sometimes we have to leverage some dose reduction. Other side effects are fatigue, some diarrhea may happen as well, and for some patients, we have to adjust the dose.
Yeah, so in patients with hormone-sensitive prostate cancer and have these specific gene mutations, very exciting update. I completely agree with you. Well, what else is exciting in the GU space at ASCO 2025 this year?
Yeah, so we saw some interesting prognostic data. It's perhaps not very, like treatment changing, but gives us some important insights. So for example, we saw in a large database of prostate cancers treated with ARPIs and ADT, which is androgen deprivation therapy, and ARPIs stands for androgen receptor pathway inhibitors. So that's essentially the standard of care for patients with hormone-sensitive prostate cancer. So we saw that patients that at 6 months since treatment initiation, if they achieve a PSA of less than 0.2, they have a very good prognosis. And this is interesting because, this is perhaps a scenario where you can test de-escalation strategies for patients with achieving that, a PSA less than 0.2. And on the other hand, you can also test escalation strategies for patients who did not achieve that. Perhaps you can, test strategies to intensify treatment and try to achieve that. So it's a very welcome biomarker of prognosis. And there are already some trials being investigated, for example, investigating the role of adding chemotherapy to this specific group of patients who has not achieved PSA less than 0.2.
So we know how important biomarkers are across all solid tumors. And I agree with you. This can become a critical biomarker to allow us to escalate or potentially de-escalate therapy into the future. Any other exciting insights from ASCO before wrapping up?
Yeah, no, another technology that is being widespread pretty much in all cancers is circulating tumor DNA, and obviously that was also presented in ASCO this year, showing its prognostic effect in patients with muscle-invasive bladder cancer. So we know that patients with positive ctDNA before chemotherapy in the neoadjuvant space, they have a worse prognosis and they have a lower chance of achieving a pathologic complete response post-treatment. And that's essentially identifying a group of patients with worse prognosis. And this is important because this can help us targeting those specific groups to intensify treatment, perhaps to have more aggressive treatments and try to get the disease under control. And the opposite is true. We can eventually de-escalate treatment for patients with negative ctDNA up front. So the more we know about the behavior of the disease, the biology of the disease, the more we can employ the correct tool to treat the correct patient.
Yeah, I couldn't agree more. And here we're seeing in bladder cancer utilization of circulating tumor DNA, as you mentioned, as a molecular biomarker to help potentially guide therapy. So very exciting updates. Dr. Araujo, it's a pleasure to meet you, a pleasure to have this discussion with you. And thank you to the Cure readership and listeners for your attention. Daniel, look forward to talking again soon.
Thank you so much. It was a pleasure to be here.